Welcome to Leadership and Motherhood, the podcast for ambitious, high-achieving women navigating leadership in the boardroom and at home. I'm your host, Leanna Lasky-McGrath, business leader, mom, and certified executive coach. I believe that every woman deserves to create a life and career on her own terms, one that she truly loves. This podcast is here to help you do just that. Let's get started. Hello, everyone. Thank you so much for being here. I have a really special episode for you today. It is a different topic than what I normally talk about here on Leadership and Motherhood, but something that is so important for so many women to hear. March is Endometriosis Awareness Month, and I wanted to bring a special conversation to talk about that. I want to tell you a little bit about my journey with endometriosis. I was going to start out by telling you when my journey began, but the truth is I don't know exactly when it began. Did it contribute to our long journey to pregnancy when we were trying to conceive? Maybe. Our reproductive endocrinologist said that it could be a factor given my history, but the only way to diagnose it is with surgery. Did it begin after I had a baby? Were my reproductive organs altered by pregnancy and that's what caused it? Unfortunately, because of the lack of resources for women's health research, we don't know a whole lot about this very common disease that impacts so many women. But I do know my story. I know that at least once a month and sometimes more than that for the past 6 or 7 years or so, I spent a majority of my day in debilitating pain. Often it was so bad that I couldn't think or function, and I would lay in bed in the fetal position all day. And it was just like no painkiller or muscle relaxer or anything I could possibly take even touch this pain. None of the heating pads or ice packs or anything. I had to cancel activities and meetings, and it just kind of rendered me pretty much useless for at least one day a month. I even went to the ER twice because the pain was so intense. I was sure that I was probably dying or that it was appendicitis because that's where the pain was located. And after those ER visits, I would be referred out to different specialists, all of whom would run their tests and find nothing. GI couldn't find anything. They referred me to a dietitian. I did pelvic floor physical therapy upon referral, and that helped some. But a lot of times when I went, I would tell her about this pain in my lower right abdomen and pelvic area. So she referred me to ortho thinking that maybe it was a labral tear, and they did an MRI and found a labral tear in my hip and a bunch of other things going on in my hip. So I had surgery to resolve that, but this pain continued. They evaluated me for a sports hernia. I had CAT scans and ultrasounds, blood tests, x-rays, and nothing showed up on any of them. Just like little things here and there, but nothing to explain my pain and nothing that was resolvable. So as I continued to have this pain and there was no explanation for it, I just wondered if I don't know, does everybody else experience this pain, but maybe they just endure it? Maybe I'm just weak. I wondered if maybe I was crazy since all the tests came back normal. Is this all in my head? I don't think that the doctors were intentionally dismissing me or downplaying my pain. I think that for the most part, I've had really great doctors who genuinely care, but I also think that they didn't know how to help me since they couldn't find a problem to treat. Nothing showed up on a test for them to do anything about. So they would just tell me I'm sorry, but here are other tests you can take or specialists you can see. So I had pretty much accepted that this was just something I had to live with. This was just a part of life. And since all of the cancer screeners were coming back negative, I thought, okay, well, I guess it's not going to kill me. I just have to endure this pain. And I had mentioned this pain at every annual exam with my OBGYN. And then finally, in 2024, she referred me to a pelvic pain specialist, Dr. Nicole Donnellan. And at my first visit with her, she listened, and almost immediately she had a theory of what was causing my pain. She believed that it was endometriosis and or adenomyosis. I had heard of endometriosis a little bit, but never of adenomyosis. But that one impacts the uterus. And she confirmed with a pelvic exam when I about jumped off the table and said, this is probably what it is. So the good news about that is that neither of those diseases are cancerous. But the bad news is that the only way to diagnose both of them is with surgery. The only way to diagnose adenomyosis is by removing the uterus to look at it under a microscope. It is crazy to me that it's 2026 and we don't have a better way to diagnose these common diseases. So she offered a few different non-surgical options to manage the pain, but essentially the only way to remove the pain completely was through surgery, through a hysterectomy. So I had that surgery in December of 2025, a few months ago, and I'm really happy to say that the pain has not returned since my recovery. It was there in the first couple weeks, and I was like, no, but then I haven't had it since, knock on wood. Dr. Donnellan was the first doctor to really listen and have any kind of idea of what could actually permanently resolve the pain rather than just like referring me to someone else or doing another test. And it took me 6 years of doctors and tests and advocating for myself to find her and to find a solution. And this is my story, but I know that there are so many women out there with similar stories. I tend to be a pretty private person when it comes to my personal health matters. So I was hesitant to share my story publicly, but when I did, I heard from so many women who shared similar stories of undiagnosed pain, years and years, sometimes even decades of trying to figure out what it was before they finally found a solution. And so many women are still searching. So if you are currently looking for an answer to your unexplained pain, I hope that hearing from Dr. D in today's episode will give you some hope that there are doctors out there who are both knowledgeable and compassionate, who understand some of these conditions that may not show up on a test, who will listen to you and help you find and solve the underlying issue. I'm so grateful that I found Dr. Donnellan, and I'm also so grateful that in my follow-up visit from surgery, when I asked her to join me on the podcast to share her knowledge on this topic during Endometriosis Awareness Month, she said yes. So I'm so excited for you all to meet her as well. If you're currently going through this too, I hope that you'll keep going. I hope that you'll keep trying to find an answer and relief, even though we shouldn't have to, even though it shouldn't be this hard. Share your story so that we can continue raising awareness and hopefully create a better situation so that our daughters, our nieces, and women in the future won't have to go through this like we have. So now that you've heard my story, let me tell you about Dr. D, and then we'll get into our conversation. Dr. Donnellan is a busy gynecologic surgeon with a strong commitment to patient care and surgical training. She has devoted her career to improving women's health through the practice of minimally invasive gynecologic surgery and the education of trainees in this important surgical modality. Dr. Donnellan has also founded and directs the UPMC Magee Women's Endometriosis and CPP Center. This center serves the women of Western PA and beyond in evaluating and treating common causes of pelvic pain. She has also established a large biobank of endometriosis tissue and collaborates with fellow MWRI investigators regarding the role of the immune system in the pathophysiology of this common and often debilitating disease. I'm so excited to introduce today's guest, my very own doctor, Nicole Donnellan. She is here to talk to us all about endometriosis and pelvic pain, and she is an expert in all of the things. But first, I'd love for us to get to know her a little bit. So, welcome, Dr. D.
Thank you. Thank you so much for having me.
Yeah, thanks so much for being here. Maybe could you start off and just tell us a little bit about you and just what brought you to this work?
If I think back to, who I was and growing up, I was definitely more of a science and math oriented person. I think if
Mm-hmm.
I could have gone through high school again, not had taken another English class, that probably would have been me. So
Same.
by default, I think once you kind of find that path, then it's kind of navigating, what within the sciences felt right. I went to college in Vermont, to Middlebury College, and up front, obviously being in the middle of the woods and the mountains and the wilderness, it was very enticing to think about environmental studies. I did a semester abroad in Costa Rica, and I soon realized that I was not cut out for the mosquitoes and the scorpions and all of the bugs that could kill you. And suddenly a controlled lab environment with air conditioning and no killer bugs was a lot more appealing to me. So I think that once I kind of realized, I think the people in National Geographic that are doing all these amazing cool things on boats and in the rainforests of Brazil may seem super, super cool. That was not for me. The content might have been, but not the environment for sure. So I really kind of transitioned at that point a little bit more to the basic sciences. I did a thesis in college in molecular biology, where I was doing a lot more of lab work. It is funny because people that end up going to medical school, really, a lot of them don't like lab work. And I think to me, it made like pipetting and doing all those things made sense because I'm a surgeon now, right? So I really liked the doing with my hands. I worked for a couple of years after undergrad at a lab in Harvard, and really enjoyed that. But the translation to the work that I was doing, it was neurobiology and looking at, pathways in apoptosis, like cell death, and a lot of kind of neurodegenerative disorders at like the level of cerebellar stuff in mice and whatnot. And while it was very, very amazing and cool, I did not see that it would help anybody in my lifetime. And I think that's where probably people then lead less from a PhD sometimes to more of an MD. So that's kind of how I landed on the MD. But then in terms of women's health, it was definitely a connection between my mom, as we had talked a little bit about before offhandedly. She struggled for many years with pain and bleeding and fibroids when I was a high school to college student. And I think back then, if you told me the word hysterectomy, would have had no idea what it meant. And I think kind of even her generation is always like a little hush hush to be protective of their children, of not really wanting to talk about their health issues, but kind of having thought a little bit about that and talking to her after the fact of living through it, that kind of got me into the world of thinking more about women's health as I entered into medical school.
Okay. So when you were in medical school, were you studying a specific?
So in medical school, your first couple of years, everybody does the same, say basic science curriculum that you're in, in the classrooms and things like that. The third, traditionally, that's first and second year, whereas the third and fourth year is where you kind of translate into doing the clerkships, like on the ward. So you do OBGYN and pediatrics and in medicine and like the general core clerkships. In my first and second year, there were a few amazing women's health internal medicine doctors, one that ended up being my PCP for a while, Dr. Melissa McNeil. They really imparted their love of women's health from a primary care perspective. They were just super active and engaged in the first couple of years, to where there's faculty members that kind of make the basic science a little bit more clinical, if you would, even though you're still just in the classroom a lot. And I kind of naturally gravitated to them, probably number one as humans, but then their content. And it is funny because a lot of people that gravitate towards them, they joke around that they can't retain them because they do ultimately. Even Dr. McNeil, my former PCP, her daughter became an OBGYN. So, our love for women's health kind of then goes through, navigations of where can you care for women in this population, either as an internist or a family medicine doc, if you're more interested in the ambulatory medical component versus OBGYN, that would be more of obviously the obstetric and or gynecologic procedural based things.
So you had some education there and some training, and then did you go straight into OBGYN from,
Yes.
I don't know all the medical school. I know you do a lot of things. So
Yeah. So after the 4 years of medical school, you do 4 years of, well, it depends on your subspecialty. So for OBGYN, it is 4 years of residency. And then when you're finished with that, can then sit for the boards to be a practicing general OBGYN, right? That you may go to for your annual exams or for your pap smears, for abnormal bleeding, for your babies. And then there are subspecialties within OBGYN, the common ones being gynecologic oncology, maternal fetal medicine for high risk OB, REIs, reproductive infertility, urogynecology, and then MIGS, minimally invasive gyne surgery. So what I did is I then did 2 years of a fellowship in minimally invasive gyne surgery afterwards. And that's where I really honed my skills in terms of under my surgical mentors, Dr. Tedley and Dr. Suketu Mansuria, of doing advanced benign gynecologic surgery. So historically, the skilled surgeons of OBGYN are the oncologists, right, that do the really advanced ovarian cancer, cervical cancer cases. But in the last 20 plus years, the advent of robotics and laparoscopic surgery, this field has evolved in taking on the more advanced cases of endometriosis and large fibroids. I left OBGYN knowing that I still really loved the operating room, but maybe didn't have necessarily the confidence to take on every case that would come my way. So I really think initially was then my passion to want to be one of the best surgeons I could be that led me to MIGS. Within MIGS, you fall within a patient population also that you have to love. I mean, everybody chooses their disciplines based upon that. So obviously loving to be a surgeon, but taking care of pelvic pain, endo, and being advocates for that patient population is how then my world has fallen into, the endometriosis and fibroid realm of things.
okay. So I'd love to hear a little bit more because somewhere along the way there, you also had a child.
Yes.
You're a mom.
Mm-hmm. Yes, I did.
Yeah. So tell us more about that.
So I would say I probably still wouldn't have had a kid if it weren't for my husband, who said, "You're so type A and there's never a good time for anything." And you were always thinking about there would be a perfect time and you were going to say an excuse that there never was. So I have a 13-year-old son, Colin. And I had him I was pregnant during the end of my fellowship, had the summer off before I started faculty again in September. And he came a little bit early. It was 36 weeks, but I worked for a few weeks before I took maternity leave for a few months. Yes, there was never a good time. But I did have a few months off in the summer between fellowship and starting when I was pregnant, and then delivered him from that standpoint.
Wow. Yeah, I just can't imagine because I know I work with so many women, I talk with so many women about how challenging it is to balance everything and be a mom and have a demanding career. And as a surgeon, I just imagine that you have a very demanding career. When I was looking at like all of your titles, you're an associate professor, you're director of academic OBGYN, you're director of the Endometriosis and Chronic Pelvic Pain Center. Like, do you sleep? Like what?
I actually do. I have somebody that needs 9 hours of sleep. Like, I can't not sleep. But I think how I do it is because of my husband. I think that I can't do what I do without him. He kind of jokes around. He is a consultant by trade and went to business school and worked while I was a med student and a resident, and always joked around that his retirement policy was my brain. Right. So he took a very good opportunity of when we had a child and having, it's soul searching for a couple, of saying two people really love their careers. That's great. We'll figure out how to raise a child. For him, he was not in love with his career the way I was. And so it made sense for him not to work. And I mean, that's fortunately how I have the flexibility. I mean, he did business consulting before, so we definitely knew the ends of my days are not predictable. He'd be on a plane all the time. So we would have needed full-time care, which 24/7 care, which is fine. People make that happen too. But as I said, was not in love with what he did. And I joke around with my son that he is definitely has way more fun by having dad at home than mom at home, because dad is way more fun of a parent than I would ever be. So I think we've both found our little places to be in life from that standpoint. So it is tough because I think women are told that, in our generation, especially, our parents, of our generation, empowering us. I know I can remember my mom always just wanting to make sure that I knew that I could do what I wanted to do, and nobody better tell me otherwise. Otherwise, they'd have to answer to her, right? And that has been filled because I have a partner that also believes that, and so until the world is ready to embrace that, I don't think people can necessarily be as successful as I am in my career unless they have the support around them to do it, as well as, in order to have a family too. I mean, it's a divide and conquer too, for sure. I mean, there are definitely things I do around the house, or if there's things that are done around the house that I don't like how they're done, I keep my mouth shut because at least they're done.
I do think that's very key.
Yes. I suddenly don't want to not have dinner put on the table because I'll just take some sort of food as opposed to no food, right?
Absolutely. Well, I love that for you. And I love that it's like your team, your family is behind this really important work that you're doing in the world and is enabling you to do this and change the lives of so many women. So I'd love to hear more about, I came to you for pelvic pain, and I had been having that for years. I think it was 6 years that, of undiagnosed pain. I was in the ER multiple times. I had done a colonoscopy, dietitian. I had done all these different things. And then finally, I was referred to you, and you were like, yeah, I know exactly what this is. Endometriosis and adenomyosis. And I was like, oh, well, why didn't anybody pick up on that in the last 6 years? And, it's not like I wasn't going to the doctor, but also at some point, I think I kind of gave up and just said, like, well, I guess this is just pain I have to live with forever. So tell me, are these the kinds of stories that you hear often?
Yeah, I mean, I'd like to say, and I share it with patients, I probably shared it with you at your first consult, is like, unfortunately, it's not the exception, it's the norm, right? And maybe tongue in cheek, you can say misery loves company to hear that. I don't know, is it level setting that, guess what? You're not, unfortunately, the only one that is experiencing that. But, I think I actually like harken back to, I think of just me saying how supportive and like empowering my mom was. But I can remember being in high school and having the worst menstrual periods and whatnot. And she just would like dismiss me. My own mom would dismiss me, right? Like at one point, I remember being in tears and she was just like, oh, forget, like kind of almost like suck it up, buttercup, So I think about that sometimes, I don't hold that against her, but I was like, if that's how someone who has unconditional love treated me, like, it's no wonder that, people like you in society are like spin their wheels trying to just be like listened to, you know what I mean? And it's interesting, like I have the discussion with a lot of patients, where's the appropriate place to start educating? Because a lot of this is, how do you educate people? Actually, one of my more recent patients works for CMU in some of their IT and education, I don't want to say department, I'm not quite sure exactly what her role is, but she was working on a project with some of her students about endometriosis and pelvic pain. And like she had interviewed me as a stakeholder and was like, all these stats of like med students maybe get one lecture on endometriosis, right? And as I explained the med school structure, that's probably not surprising. Think about everything in 4 years of med school someone has to be subjected to. So I was like, but to be honest, what I said to this patient and colleague now of mine, enhancing an endometriosis curriculum in med school, I don't think is going to do anything because, you're just learning so many things, and the people that actually matter to be like for me to empower are actually more like quote unquote adult learners beyond that. And so I feel like actually what's been really empowering to me in like setting up our endometriosis and pain center is just how much we learn from each other. I mean, I think a couple of my GI docs and this one young woman, Dr. O, that now works with us, Sunny O, she's like, I can't get over how much I've learned just from working with you guys for like a few years. And she's like, it now seems like a no-brainer to me when I think about this. So she now has taken it on herself in the gastrointestinal, GI world to like go to national meetings and be like, you guys, we need to think about endometriosis, like every fellow that comes through. And I'm like, I think that's kind of where some of the education, at least in the medical field, has to be, is where are these patients like you having touch points, right? Like, I mean, someone that's neurosurgery bound, right? That was my Pitt Med classmate, probably doesn't need to know about having, 10 extra lectures on endo. That's not where the needle is going to move. But people that you have said, I had a colonoscopy, I had this, I had that, like, why did it take 6 years of umpteen providers for somebody to like think about this, right? Like, so thinking about empowering and educating the family medicine and the PCP, and even some of our general OBGYNs aren't all that great at it either, from that standpoint.
Yeah. So in terms of what I can do to help, because when I shared about this, I heard from so many women and women's partners reaching out and just saying like, I went through this, one woman, it was 16 years and had just had surgery to fix the issue. What would you want to share? And maybe we start with like, what is endometriosis and what are the symptoms? Because when I came to you, I was familiar with endometriosis, but whenever I talked about it, not a lot of people were super familiar with it. They're just like, oh yeah, that's like a woman's thing, right? And then adenomyosis, the first time I ever heard that word was when I met you, in your office. And so that seems like way less commonly known, but seems very common, at least from the conversations I've had since being diagnosed. So maybe we can start off by just helping to educate the general folks listening.
First, starting endometriosis, it is textbook. I always say the cells that we shed, endometrial cells with our menstrual cycles, those glands and stroma, can, for whatever reason, and it's crazy that we know very little about this, and even though it's 2026 for how common it is and for even how much I see it, but they can kind of plant throughout the pelvis and beyond and cause a pain syndrome. Adenomyosis is akin to that. Those cells we shed start growing into the wall, the myometrium or the muscle wall of the womb, of the uterus, and similarly can create a pain syndrome. Again, $1 million question. There's lots of theories and hypotheses as to why these conditions occur. And there's lots of basic science, translational science, trying to understand the natural course of this disease, let alone diagnosis and treatment options. The good thing, I think, bottom line, is I say this is benign. I say I have a love-hate relationship with the term benign, right? It's benign. It's not a cancer. It's not a precancer. Might kill us from going crazy. It's not going to kill us, though. But I hate that because for all the things that you talk about here, it just brushes under the rug stuff that is already brushed under the rug, right? So, quality of life is nothing but benign in that for these conditions. So they do overlap in the sense that they can present with very similar things, or very similar symptoms. But I think also the hard thing is when I will name a lot of the common symptoms, there's a lot of things that present with that, right? So herein lies the issue. So, classically, any patient that comes to me may or may not have pain with their periods, just pain all the time, pelvic pain, pain on their left, pain in their right, pain in the middle, pain in their vaginas, and then there's always the associated pain. So not just the pelvic pain or menstrual pain, but it's, associated with the bladder function, associated with bowel, associated with vaginal penetration or intercourse, right? All of these things. I oftentimes try to keep it light, say, the pelvic region's a black box, and there's a lot of shenanigans that go on in that black box, right? And as in broad strokes, thinking about it, I'm the gynecologic person. And even within gynecology, right, we just named two, endo and adeno, but you can have fibroids, you can have cysts, you name it. It can also just be the regular menstrual period can be pretty inflammatory. But apart from the gynecologic stuff, there's all these other things, right? The gut, so the GI stuff. So you can end up in your GI doctor's office. The bladder is there. You can have overactive, painful bladder, used to be called interstitial cystitis, the pelvic floor and musculoskeletal stuff. And then there's also the mood, right? And I tread lightly with behavioral health because, understandably, patients have been ignored and dismissed. So it's like one of those chicken and the eggs, like, yeah, you're going to feel crazy if everyone tells you you're crazy, right? So like what came first? But joking aside, like the behavioral health and making sure people's mood and mental health is in a good place is super important because no physician can really try to help you if you aren't in a good place with your mood. So I think that kind of underlies all of it. So it isn't surprising that somebody says, oh, I have bloating and pain when I poop and terrible GI issues. The last person they're going to think about is going to their gynecologist, right? I don't know, maybe. So it's not surprising that perhaps if that's somebody's chief complaint, it's going to take handfuls of years going through many other places before they maybe get to me,
Yeah. Well, I guess how prevalent is endo?
It's a good question. Historic data that we have says, and I think this was founded in like a paper that was just like at time of like tubal sterilization. So clearly, probably people that didn't have fertility issues. I didn't even launch into infertility as stuff, but like fertility issues or pain issues, but people are getting their tubes tied. I think there's just a baseline incidence, even in asymptomatic people, of about 10%. So you can see endo. It may or may not be the source of issues. But if you then focus in on a group of patients that come in complaining of or being bothered by a myriad of those things that I just listed, it's anywhere from like 40 to 70%. So it's common. I mean, I think we say 6 to 7 million people in the US. I mean, it's a lot of reproductive age women. Put it this way, if it was a predominant man's disease, we'd probably have a better answer for it, right? So
Sure. Absolutely. I remember you telling me that in my first visit, that unfortunately there's not a lot of research on this, which is unfortunate. I pulled a couple of quotes as I was doing some research on you and your work. And one of the things that you have said is, as a surgeon, I take great pride in educating the next generation. However, as a researcher, I remain appalled that the only way we can currently diagnose and treat this crippling disease is by surgery. It is the 21st century. We owe our patients more than this. So can you talk about the diagnosing of this?
It's hard because even as an as an endometriosis expert, when just yesterday I saw a handful of people in our endo center, and a common question is, so even if they're signing themselves up for surgery, do you think I have it? And I was like, I don't have the ability, even as an endometriosis expert, to have a better sense of it. I said, I think our power is that we're thinking about it, right? It is crazy that it's 2026. And the only way I can tell you, somebody like you, that you have endometriosis is by doing a surgery. That being said, there is a more advanced disease. Like you can have deeper infiltrating disease, chocolate cysts, you may have read about, right? Like of the ovary, endo of the ovary. There is some imaging that you can pick it up on, but earlier stage disease, which again, stage doesn't portend, you can have a little bit of endo and have terrible symptoms and vice versa. So that's the other problem. Is like normal exam, normal ultrasound doesn't mean you don't have endo, right? So the only 100% way to diagnose this is by doing a surgery. And understandably, that's high stakes. And I mean, you get in there and oftentimes it can be tricky surgery. So, we have as subspecialists, I feel comfortable taking someone, not to be cowgirlish or cavalier, but I can deal with a lot of what I get into. But you do wonder also if there is understandably people that might not feel comfortable getting into that situation, even to put a scope in, even if you don't have to do anything, and say, hey, yes, you do have endo. Now let's see if we can get you, because they don't maybe feel comfortable getting to that point, right? Because it is a pretty advanced disease process in a lot of situations. So there's no blood test right now, no definitive imaging, short of some of the carve-outs I said. And there's a lot of translational work going on. I think that the hard thing, and it's very humbling, I think, for my basic scientists and PhDs, because I, in the past handful of years, have gotten a lot of excitement and momentum from investigators, both locally at the Magee Women's Research Institute, Pitt School of Engineering, Swanson School of Engineering. I have collaborators, and even nationally. But you start talking to the basic scientists about this, their minds are blown because it's very heterogeneous, right? Like even when I look in at someone's pelvis, as opposed to like a fibroid, right? A fibroid that's like a smooth muscle tumor, that's like a little mass on the uterus. That's also could have a whole nother podcast on fibroids. There's a common etiology for pain and bleeding, also in women's health. It's easy to diagnose. You see it on imaging, and it's like a fibroid is a fibroid. But like endometriosis, like an endometriosis lesion can look like a vesicle, can look like a red flame lesion, can look brown. And so, number one, people have lots of different symptoms. Number two, it can be all over the place in the pelvis. Number three, it can look very different all over the place in the pelvis. So suddenly the basic scientist that wants to set up a beautifully controlled environment for some sort of trial, his mind is blown. So I do think, yes, women's health research is understudied and underfunded and underappreciated. But I think then when you actually take these scientists that are interested in doing it, it's really hard. And it's interesting because adenomyosis throws another wrench in it, because as you said, you can have two of these that coexist. But again, you can pick up adenomyosis sometimes on imaging. But the only 100% way to ever, as we probably had a discussion, tell someone they have adeno is, guess what, with a hysterectomy specimen, right? And clearly that is not what everybody wants. So if I have a young individual that I go in and do a scope, I can prove that they have endo or not. but I can never prove they have adeno or not with any certainty unless I take their uterus out, which, right, like, 2/3 of my patients, I'm not doing that on. So that's a whole nother like confounder that my basic scientists are like, oh my God, like, how do we account for that? Like, I don't know. So it is very humbling.
Yeah. So is there progress towards, diagnosing without surgery?
I think there definitely is. Internationally, a Canadian researcher is doing a lot of work on more focused and advanced ultrasounds, which I think, similar to how we are training up in our MIGS fellowships, more advanced surgeons, there probably will be pathways for people to train in that. But it does take a skill. In terms of when we think about the translational or basic science for diagnostic modalities, we're looking for blood tests. We are working. I know there's lots of groups across the country and internationally that are doing that. The problem is that it's kind of like the law of large numbers. When you have a very heterogeneous condition, you need thousands upon thousands of people. So they're starting to try to unite a lot of the research groups throughout the country and the world, because I think the power is going to come from bringing these people together. But that's politically charged a lot of times too, right? Scientists are very, very protective of their domains. So I think that's going to take kind of the greater goodwill of wanting to get people together. One of my basic scientist colleagues, Dr. David Peters at the Research Institute, he always talks about, when I'm the Debbie Downer saying like how heterogeneous this is, he's like, in order to study this better, we have to think about the population, not like just a couple hundred individuals. And so can we harness something, say like a pap smear, right, that screens for cervical cancer screening, that we have access, Magee probably has how many pap smear specimens kicking around for every year. And is there signal on that we could use, right? Because I think, there's a finite amount of resources to say we can biobank, every person that we take to the OR in this country, right, to look for blood signaling and whatnot. But I do think you kind of have to think larger scope to start seeing what's important. When you think about like screening and blood tests, there's a lot of non-specific signals and a lot of things we kind of start discovering, but realizing like what's the sensitivity and specificity of that and how much better is it than just taking someone to the operating room. Like, right, if I had a blood test that said, okay, with 80% certainty, maybe you have endo, are you going to come to me and be like, okay, but what about 20%? I mean, it's not as high stakes as with cancer, right? That you want to be a lot more certain than cancer. If you miss endo, you miss endo, right? If you miss ovarian cancer, that's worse. But like, you have to get probably pretty high to avoid having a patient that's struggling with really, really bad pain for them to say, no, even with like 90% sensitivity, 95%. I mean, I don't know what that cutoff is to be certain that if that blood test is negative, you don't have endo, right? Like it's tough.
That makes sense. It's been really interesting as I have navigated this myself and talking with other people about it, and sharing that I had a hysterectomy, and also looking at what my questions were whenever we were talking about it, just how little the general person knows about a woman's reproductive system and organs. Because even the women in my life, they're like, wait, so a hysterectomy, like, what is that? Like, does that mean you're going to go through menopause? What does that mean? And I didn't really know either, to learn that I would continue to have cycles and like, but what does that mean if I no longer have a period? Like, it's been really eye-opening to me. And to your point earlier about how our moms didn't really like talk about this as much with us, it's just like, what is the general thing they need to know? But then beyond that, it just seems like we're so undereducated just on basic women's anatomy.
Yeah, I mean, you bring up a good point. It's true. The understanding of the female reproductive tract is crazily unknown or misunderstood by the common layperson. You know what I mean? And I think, yes, the most common thing is I will have people that come in to see me and are hell-bent on not wanting a hysterectomy because they're going to go into menopause. And I was like, wait a second. No. Like the ovaries are a totally different thing, right? Like, I mean, don't get me wrong. There are reasons that we take ovaries out, really bad endometriosis and risk reducing surgeries and stuff. But if someone, quote unquote, has just adeno, meaning it's confined to their uterus, not to belittle what adeno is, but right, like just adeno and doesn't have anything else, the ovaries are very rarely the cause of a problem, right? And so, the discussion we have is those guys are flapping, I should say gals, those gals are flapping in the breeze, and, they're going to do their thing, and they're going to keep giving us hormones, and we want to keep them in for, future heart health, bone health, mental health. But yeah, so total laparoscopic hyst, the word total freaks people out. Total actually medically refers to the uterus and the cervix. Now, there are times that is appropriate to keep or take the cervix, but that's what total is, right? People in lay speak hear total and they think that means like their ovaries.
All of it. Yeah.
Whereas I have to say, no, yeah, total is not. The tubes and ovaries are different words, right? So, and are different procedures. But it is, yeah. I mean, I think it was a resident project a handful of years ago. One of my colleagues, Dr. Judy Chang, who does a lot of qualitative and interview-based research, one of the residents did this really very fascinating interview-based project on IUDs, intrauterine devices, in the concept of interviewing people as to why they didn't, if they declined it, like what their fear was, and kind of getting at that, right? In going through the knowledge or lack thereof of where an IUD goes and how, it was just mind blowing, the misconceptions. It's one thing for things to be passed down for fears of it if people have bad side, but like just even the total misinformation of, you can have your opinions about it, but having it grounded in anatomic facts, right? And just even those baseline facts not being understood. Yeah.
Yeah, it's really eye-opening, alarming, concerning.
Yeah.
It just seems like this is something we should know about. I shouldn't have gotten to my 40s without knowing all about like what's inside of me and how my body works. But that seems to be very common, unfortunately. That's been an interesting thing on my journey of just, I've learned so much, and I'm so thankful that people like you exist. So I know we're talking mostly about endometriosis, with it being Endometriosis Awareness Month here in March. And we also are talking a little bit about adeno. We talked about fibroids and some other things. Are there any other things that maybe if a woman is struggling with pelvic pain or intense bleeding, are there other diagnoses that you find that are somewhat common, or that maybe they should think about to bring up to their OBGYN at their next appointment if they're experiencing something?
Yeah, I think something that we see a lot, especially when you think about amplified pain, is the pelvic floor dysfunction that comes along with a pain syndrome. Now I say, and that's like just the primary term, or it would be like vaginismus, right? It's just like hypertense muscles in the vaginal area. Sometimes that can be primary. And unfortunately, is that just because somebody has had medical trauma, like a terrible first exam, has had, unfortunately, some sort of abuse history, but also can be secondary to terrible pain that's just been mismanaged or undiagnosed. And I say, that fire or whatever is causing pain in the belly area, in the pelvic region, is causing a vicious cycle of spasm in the vagina. I level set and say it's just a little bit like an orthopedic injury that, again, is a little bit more commonplace to hear of. You tear something in your rotator cuff, you have a frozen shoulder, you need to rehab, you get that frozen shoulder, you can't brush your hair, right? You need to rehab that, but it's because there's something that happened in your shoulder. So, a lot of times we do find a lot of spasm in the pelvic floor when we're doing an exam. And I think I'm seeing more and more of that identified. That's an easily found thing on exam. Again, what is then the underlying reason? You may or may never get an answer for that, right? But pelvic floor physical therapists that are excellent and exist throughout the community, that they are orthopedic trained, but trained extra to be experts of the pelvic girdle, can go a huge long way in helping to address pelvic floor dysfunction that is, kind of rampant in patients that experience ongoing pelvic pain, for sure. So I think that's something to bring up, that maybe some providers are not aware of the resources that can exist in sending someone to pelvic floor PT.
Yes, that was part of my journey as well. I did that. And then she discovered that maybe there was a labral tear that was causing the pain. And so then I went to ortho, and then I had a hip surgery and repaired that because a labral tear was found. And I said, but is it going to fix this pain right here? So, of course, then my ortho thought maybe it was a sports hernia. So then I was seen for that, and wasn't that. And so I echo the benefits of pelvic floor PT?
The important part of that when I'm recommending PT, I mean, sometimes it is, somebody is not ready to have a surgery, is not ready to have their uterus out. And what can we do to empower them? I say, my ultimate goal is for you to have control over the pain rather than the pain to have control over you. And even if you would feel 100% better with a surgery, that's not the right answer for everyone, right? And perhaps they can't take a hormonal medicine because of side effects or a prior medical diagnosis. Something like physical therapy is definitely, even in people that have the adenomyosis, is definitely, I've worked with some physical therapists that we've gotten a woman to another pregnancy by getting their quality of life up a little bit to manage the terrible flares of the back pain and the vaginal pain that go with that adenomyosis. I think what underscores, as you say, you go from here to here, is that it's definitely 1+1=4, right? Not 2, and that all of this synergizes, right? So while yes, there are carve outs that someone's looking to avoid, a few other things that I think would also help, PT plus perhaps medicine, plus minus perhaps surgery, plus minus seeing your GI doc, all of these things, although they are obviously huge asks and lifts to have a patient navigate and see these. That's why like our network of our endo and chronic pain friends that just keeps growing and growing is so powerful. I tell my patients very rarely, can I succeed just as a surgeon in isolation, right? I need to rely on a lot of these other ancillary services or doctors to also optimize some of the other things. The same way sometimes people end up with me because they primarily have a really bad bladder complaint, but we need to make sure there's not endo that could be flaring it, right? They kind of feed into each other.
Yeah. I want to read something that I found on one of the many websites that's out there about you. It says, Dr. Donnellan is dedicated to ending delayed diagnosis and unnecessary surgery from chronic pelvic pain and endometriosis and provide compassionate expert care to end years of suffering for thousands of women. So I'm curious, obviously not everyone listening to this is going to come into your office and see you. Not everyone's in the Pittsburgh area. And so what would you say to a woman who's been experiencing pain and hasn't found a solution yet?
Is keep pushing. I mean, there is, as frustrating as it is, well, yes, maybe you're not blessed to be in Pittsburgh and be able to work with our group. There are more and more and more groups throughout the country that are starting to recognize the importance of multidisciplinary care in the various diagnoses or etiologies, if you would, of pelvic pain. Advocating for yourself sometimes gets exhausting. But I mean, if you have pain, you have pain. I joke around with patients. I'm like, you'd have something better to do than come to see me in the office, right? Like, I believe you have pain. I may never know what it's from, but I think everybody deserves to have somebody that's going to listen to them, number one. And I think that goes a long way, and empathize with them. I mean, you can, again, level set that there may never be a cure for this, and that's the sucky reality of it. But how much can we slowly work towards improving quality of life a little bit at a time, and just have, for me, I also sometimes say I'm the PCP of the pelvis, right? Like, I may or may not be able to help you from a surgery because you may not have endometriosis, right? You may end up here because we just happen to be a group of doctors that take care of endo and happen to listen, right? And I think that's super powerful. And then trying to navigate and be your advocate and champion to navigate through the healthcare system, which is obviously, it's not easy for me as a doctor to do it for my patients, let alone having patients try to do it. So I would say keep pushing till you find.
Yeah. Well, I think to me, the key thing that you said there was that you believe them, because I really think that that is what can be so disheartening and have us start to question, like, is this just normal pain? Is this just being alive? Is this just part of being a woman? Because, you go and tell all these people about this pain and they look at you and tell you, well, your tests are normal. Well, everything looks fine on, your blood work. I had every test done and nothing showed up. And so you feel like maybe someone is telling you, well, like, your pain isn't real, or we don't believe you, or it's probably not that bad. And you're like, well, no, like, I just spent the entire day in the fetal position, unable to get out of bed. Like, it's bad. But I don't know how to get you to believe me about that whenever, you're only looking at this set of tests as your only way of deciding if you believe me or not.
It's interesting because on the flip side, when I think about it as like training the provider elements, because some trainees will just like, Nicole, like this must be exhausting. Like, how do you take care of a chronic pelvic pain population? And probably if you asked me 10 or 15 years ago, I probably would have been like, no, why would I do like I'm a surgeon. I like to fix things, right? And why I'm taking care of a population where a lot of times I can't fix people, right? I can help them, I can support them, but I can't fix them. I think I harken back to one of the first write-ups that the MWRI did of one of my patients. It was funny because this person had just written in and been like, she was a freelance writer, but anyways, she had reached out unprompted and is like, I just want to write about my experience and about Dr. Donnellan. And so like the people at MWRI had like, we had like done little interviews, whatever. And I looked up her name, I'm now like in good touch with her because she does a lot of like media relations stuff. But I remember, and if you had asked me, this would have been like a patient that when I would see her come into the office, I would be like, oh God, it's her again, because I just don't know what I'm doing. Like, I just felt so helpless, right? Like, I felt like there was nothing I was doing. But after hearing her perception of that, it's exactly what you said. It's just like, she would just listen, and she actually would validate what I was saying. And so I do try to impart in my trainees that like, it's crazy to think that there are physicians out there. Like, I'm not sure why you would go into medicine if you're not going to believe people, right? Like, I mean, but my existence is that I have to like sit here and believe that you're coming to me, not because you're making stuff up, right? Like, I mean, again, you don't have something better other than kind of spend 45 minutes and have a doctor's appointment with me on a Tuesday afternoon. But I think that unfortunately you do hear it over and over again that you're the first person that listens. And I'm just like, wow, like that's actually a pretty low bar. Like, I don't have to be super great. Like, if I just have to listen, I mean, kind of tongue in cheek, but like, that's where you kind of have to level set of like, there can be, I mean, early on in America, it's like a level of exhaustion that you're like, okay, I need to fix. But it's kind of just almost like it's a team sport, right? Like, I would say now I've come to the point that I get more frustrated when there are people that continually come in and perhaps keep coming in to tell me the same thing, but aren't doing things I recommend, right? Then I'm just like, I'm sorry, like this is a two-way street. We have to come somewhere in the middle. Like, you can't keep telling me the same thing and complaining I'm not listening and I'm not helping when I've offered 7 different things and you just, for whatever reason, haven't done it. So that's a different level of frustration. But I think that though, for sure, it's a team sport, and like we're trying to meet somewhere in the middle from that for sure too. But definitely the empathy and the listening is huge.
Yeah. Well, I think you look at it as a low bar because it comes naturally to you. But for whatever reason, it's a very high bar in much else of the medical field, it seems, at least from my experience and the experience of so many women that I've spoken to. So, I mean, I guess you could have skipped all those years of med school and just listened to people.
Exactly, right?
But I think it also makes total sense that, as a surgeon, you want to fix the problem, that makes sense as well. I think as our listeners are high achieving women who similarly, want to solve the problem. And so that makes sense. And I think though that in this, sometimes the problem is just nobody believes me. And I think I'm going crazy because I'm having this pain that nobody can find on any test. So just please believe me. And that does solve a problem in a way. Obviously, it doesn't relieve the pain, but maybe there are just multiple problems there.
Well, I think the psychological distress that goes along with that too, like you said, I mean, I can't imagine what that would be like if you're having physical debilitating pain that can't allow you to function. And then you go to see a expert or a healthcare provider that then doesn't believe you. I mean, at some point, that's why I mean, I think there's quoted to be like 80 to 90% of patients with pelvic pain and endometriosis have some mood disorder diagnosis. Like, that's not surprising, right? I mean, I think that it's a difficult thing to cope with and deal with. And so obviously anxiety or depression or ADHD, that's going to be pretty rampant, even PTSD after you've been mistreated in the medical field. That's tough in that regard. And it just keeps feeding into that vicious, downward spiral.
Absolutely. Well, I thank you so much. Thank you for helping me, and thank you for helping so many women, and thank you for coming on my podcast. And I'm just so grateful to you and so grateful for the work that you're doing. Is there anything else that I didn't ask you about or that we didn't touch on that you feel like you want to be sure that people know?
Thank you so much for highlighting some of those quotes, because I do feel like those are things that I live by in my career and advocating for people and helping. It's funny because my program director from many years ago, I think what is a little bit more textbook in our fields of advocacy, whether it be political advocacy, you think more about abortion and Roe v. Wade. And I remember just being like, I'm not an advocate, and she looked at me and she was like, what are you talking about, Nicole? You are an advocate. It doesn't have to be abortion care, right? Or it doesn't have to be whatever, women's rights to vote or something. She's like, you speak for all of the people that aren't listened to for pelvic pain. So, I just think it's a privilege and pleasure to do that, and, helping people to then continue to support themselves to advocate, because you just kind of keep pushing.
Wonderful. Well, thank you so much for being here, and thank you for sharing all of this with us, and thank you for your work.
Thank you.
All right, everyone. Thank you so much for tuning in, and we will see you all next week. Thank you so much for listening to Leadership and Motherhood. I genuinely hope you're walking away with something helpful that will positively impact your life. If this podcast resonates with you, it would mean the world to me if you'd support the show by leaving a 5-star rating on Apple or Spotify, sharing an episode you loved with someone you care about, and/or by following the show. I hope you'll join me again next week, and until then, I'm wishing you all the best in this season of your one and only precious life.